Right. Good afternoon and welcome to the Department of Medicine Grand Rounds hosted by Hamilton Health Sciences. I'm pleased to introduce my colleague today, Dr. Hugh Traquair. Dr. Traquair is an assistant professor in the Division of General Internal Medicine, primarily based at the Hamilton General Hospital. His academic interest is focused on simulation training and point-of-care ultrasounds, works in training our residents and building curricula for simulation and code blues. From that experience, Dr. Traquair is going to talk to us today about the impact of cardiac arrest on family members. I was chatting with you earlier and say, I'm so intrigued and looking forward to learning what's new in that space. As I grew up in an era where we kicked the patient's out, family, not the patient, we resuscitated and we kicked the family out. So I'm looking to learn new skills from you. So without further ado, you, please go ahead.
Thank you very much. So I'd like to start by acknowledging that the land on which you're gathering is the traditional territory of the Haudenosaunee and Anishinabe nations. This territory was the subject of the Dish with One Spoon Wampum Belt Covenant. This was an agreement between the Iroquois Confederacy and the Ojibwe and allied nations to peaceably share and care for the resources around the Great Lakes. So today I'm going to be talking about the impact of cardiac arrest on family members, as Dr. Azam mentioned. So we'll be talking about the effects of having family members present during a cardiac arrest. We'll understand the different ways that a cardiac arrest can impact the families of patients. And we'll talk about some evidence around the care needs of families, both during a cardiac arrest and afterwards. I don't think I need to really spend much time on how important cardiac arrest is, but I will do a little bit of discussion around terminology. So throughout this talk, we're referring to sudden death. So someone who has generally collapsed and had loss of pulse. Also in this talk, we're generally going to be discussing patients for whom resuscitation was attempted. So generally speaking, we're not going to be talking about patients who had an advance directive saying that they did not want to be resuscitated, or patients where their death was expected. We are mainly talking about collapse, sudden loss of pulse, and resuscitation. In the literature, this gets divided into in-hospital cardiac arrest, which is where most of us who do inpatient work have most experience, and out-of-hospital cardiac arrest, which is mainly the realm of paramedicine and fire and rescue. We'll talk a bit about how those environments can be different and how that can affect the evidence. Very generally, after a non-traumatic arrest, survival to hospital discharge is quite low. This is a pretty good number relative to where things were 50 years ago or even 20 years ago. We've come a long way, but this is still a catastrophic event, and most of the time we are not successful in bringing people back. In the context of improving resuscitation care, there's also been a growing body of literature about the impact that a cardiac arrest has on the patient's family members and what we can do to try to mitigate some of those impacts. So why am I talking to you about this? As Dr. Zam mentioned, I am the simulation lead for the internal medicine residency simulation curriculum, which means that I organize and run an event every year, instructing junior residents on cardiac arrest, running simulations for them to help them prepare to be second-year residents who will be in charge of running code blues. This is primarily medical training. It's not as much about the logistics, and it doesn't really include very much at all about interaction with family. So questions came up, and I was asked to see if we could incorporate more on interactions with family into the curriculum. So I went to write that, and I realized that I thought I knew a lot of things, and I didn't have anything to back up my thoughts. So it was a good learning opportunity for me, and I thought I would share a couple of interesting systematic reviews and try to build up all of our knowledge in the same way that I'm thankfully built up mine a bit. So one of the big questions that we'll be talking about is whether to have family come into the room. As Dr. Azam mentioned, this is a topic that has changed dramatically over the last couple of decades, and there are legitimate argues in favor of bringing family in and against bringing family in. When it comes to arguments in favor, as you can see, they mostly, I would say, come down to hopefully improvements in the well-being of the family members. The arguments against having family in the room mostly come down to concern that there will be impacts on how the cardiac arrest is run from a medical standpoint. So the arguments against having family there include a lot of these in-hospital arrests particularly are very busy, they're chaotic, the rooms are jam-packed with people already, and adding in people who are likely upset, crying, asking questions may cause disruption, it may distract people. There's also concern that the healthcare team, and particularly the person leading the Code Blue, may be influenced by having family members in the room in a way that they shouldn't be. So not even necessarily that they're being convinced of something, but they may be more reticent to call an end to the resuscitation if the patient's spouse is watching the event. There is also the concern that having patients' families in the room may be traumatic. So as you can see, a lot hinges here on the impact on the family members themselves. So one of my questions going in was, what are families' experiences like? How does being there impact their well-being? Because if it's generally a negative experience, well, that washes away a lot of the arguments in favor. Whereas if it's usually a positive experience, or at least one that brings some closure and some reality to the situation, well, the arguments against are generally things we can mitigate. If there's too many people in the room, you kick out some of the people who aren't necessary. If the room is too loud, you quiet people down. And hopefully experienced healthcare providers are going to make decisions based on the medical situation in front of them rather than who is in the room watching them. I can tell you a little bit about local teaching because I trained at McMaster and I teach at McMaster. So I was taught throughout my training, it was generally a good idea to offer to have family come into the room. This is, again, in the in-hospital setting, we're usually talking about something 5 or more minutes into a cardiac arrest. We've often had to call people in, or families have been moved out at the start to make room for people coming in and they're waiting in the hallway. So I was taught, the code's been going on for a little while, you're running the arrest, you can bring the family in at that point. I've also gone through some simulation training in the GIM program where there's a simulated family member as part of the training. They may be there to ask questions. They may be there to be disruptive. Maybe they have a medical emergency from the stress of watching this event. All of these being designed to make the simulation more challenging and really push trainees on their skills. So that's, I would say, the state of teaching for at least IM and GIM. What about our society guidelines? So the European Resuscitation Council suggested that having family members be offered to come into a resuscitation was a good thing. The Australian and New Zealand guidelines supported this as well. I copy-pasted the phrasing from the AHA guidelines in because I found it very strange. They their phrasing doesn't make a lot of sense to me. They say there's evidence for benefits to families. There's no apparent negative effects on outcomes. So it represents an important dimension in the paradigm of resuscitation quality. I honestly don't know if they're trying to be supportive or they're just trying to avoid making a strong statement one way or another, but I found that kind of strange. So what does the evidence say about the specific question of families coming into the room during resuscitation, during a cardiac arrest? I'm going to be talking about this paper. It's a systematic review on precisely this question from only a year and a half ago, put together by the ILCOR task force. This is a systematic review of almost any research paper that included family presence during resuscitation. So very, very, very broad. There did not have to be randomization. There did not even have to be multiple comparator groups. Simply, if there was a study where there was an arrest with resuscitation and family was there and they measured something, you're in. They did, screen things down and try to make it a bit more specific, but the goal here was not to be incredibly rigid. The goal was to get a broad sense of the literature. So their studies included outcomes for patients, family members, and healthcare providers. As you can see, not every study included every outcome. There's 31 studies, and they collected different pieces of information. Some were quantitative, some were qualitative, some included patient and family, some included only healthcare provider, a real mixed bag. So in light of this, this was not a meta-analysis. There was no attempt to synthesize and combine outcomes. This was simply a systematic review and summary in a format which I'll go through with you. Can make it a little bit hard to interpret, but that's the nature of the literature as it is right now. First things first, there may have been some differences based on the setting of the arrest. As you can see, this was mostly in-hospital cardiac arrest, but going through the paper, they didn't split out in their results that they were describing in-hospital versus out-of-hospital. And the environment is very different between those two. So in out-of-hospital cardiac arrests, often the family are there right from the start. They may have been the ones who witnessed the arrest. They may have been the ones who call for help. They may have started resuscitation. So they're already there. There's also generally fewer healthcare providers. And it's often taking place in an environment where the patients and their family, it may be their house. They know the environment. If they need to sit down, they know where the chairs are. If they need to get a glass of water, they can walk to the kitchen. Whereas in hospital cardiac arrest, families are often arriving because we called them. So they're not already there. They didn't see what happened. They have to be brought up to speed on everything. And the room is more chaotic. It's harder for them to make themselves heard depending on the situation. And if they want a glass of water, they have to find someone who knows where the pantry is and knows the code for it. If they want to sit down, someone has to go find a chair. It's a very different environment. That may lead to some of the discrepancies in the results here, which we'll talk about, but it's hard to say for sure because it wasn't reliably reported. So first things first, patient outcomes. Did having family members in the room affect what happened to the person mid-cardiac arrest? Overall, not much convincing impact. Most of the studies were neutral on return of spontaneous circulation, survival of discharge, and length of resuscitation. The way I've summarized things here is on the left, you've got the outcome. And then this is a description of the number of studies that found a particular impact. And when I say positive, neutral, or negative, that is from the standpoint of a good thing or a bad thing. So a positive impact on ROSC is more patients achieving ROSC. A negative income is fewer patients getting a pulse back. Duration of resuscitation is a bit of a challenging one because it's hard to say what's a positive or a negative impact there. But thankfully, there was one study that found resuscitation was longer with families in the room, and one that found that it was shorter with families in the room. So that worked out for the sake of my graph, at least. Overall, like I said, not much impact. The trial that showed less return of spontaneous circulation and less survival to hospital discharge, that was all one trial that reported both of those outcomes. The rate of arrests being witnessed by family members was about 15% of their total. So the numbers were quite small. And it's hard to know how to interpret these. So say you do find that there's less of return of spontaneous circulation with families witnessing the arrest. Is that because the arrest gets disrupted and the outcomes are honestly worse? Or is it that family arrives and says, oh no, my loved one would not want this, and they stop, and is therefore there's no chance of developing return of spontaneous circulation? That's really hard to gather from this data. And I think overall, the bulk of this suggests that having family members in the room, there's no signal that it hurts the patient's ability to recover from the arrest. What about outcomes on the family? So we'll go through a few different sets of outcomes, starting off with impacts on mental health. Hard to interpret these. Two studies showed a positive effect on depression, fewer symptoms. One showed worsening symptoms, and the positive trials, one showed an odds ratio of 0.26, so a quarter, much less depression after witnessing the arrest. The negative trials showed an odds ratio of 6.7, so much more depression. That's a tough thing to interpret. These are small studies. I imagine a lot of that is just based on how they assess their outcomes, when they assess their outcomes, and just random chance. Anxiety, there was a neutral or maybe positive effect. PTSD was interesting because I think this is the most obvious problem that could directly stem from witnessing a cardiac arrest. Seeing something traumatic could obviously lend itself to developing PTSD later. But again, the evidence was pretty mixed here. There's no clear signal that it's always a negative thing that always leads to more post-traumatic stress. There were subjective reports from family members as well who witnessed resuscitation. As you would imagine, some positive experiences where family members felt they were able to have some meaningful communication with their loved one. They were able to ease their passing or gain some meaning for themselves. And there were negative experiences, they found the chaos really hard to deal with. They saw all of these artificial instruments being applied to their loved one. So real mixed bag there as well. And I wouldn't want to attach a value judgment to that necessarily, because people, as we go through, people have complicated reactions to things like this. Grief can be very complicated. So some people may have an experience that is traumatic and difficult and still be glad that they were there. This is a really challenging thing to attach a specific good, bad label to, as much as we try. So, for example, in one study, the vast majority of patients' family members would want to make the choice to see a resuscitation again. Most felt that the majority being about 60 to 67%, they felt that being there was meaningful, that it was important for their loved one, and it was important for themselves. Some studies also looked at regret. Generally speaking, rates of regret were quite low. There's a lot of heterogeneity in how they looked at this, but one study found absolutely nobody was regretting having seen the resuscitation. Another study found that a few people did, but there were substantially higher rates of not having witnessed the resuscitation and regretting that and wishing that they had actually been in the room. One study looked at the way the family interacts when they're in the room and tried to assess behaviors. Some things were very common. So trying to get information from the healthcare team, provide information, talk about goals and help make decisions, very common. Crying and freezing up, also pretty common as you would expect. Um, Things that might be disruptive were quite uncommon. So aggression and outright conflict were very, very, very uncommon. Um, I have some trouble with agitation sometimes in the healthcare context because it's hard to know, was this someone just exhibiting extreme grief and not doing things that are disruptive, or is this someone truly developing almost pathological agitation, interfering with care? I don't know. I would say based on the personal experience I have, I would say less than 1 in 12, fewer than 1 in 12 codes have a family member who's actively disruptive. So I wonder if it's just that's one end of the extreme for grief reactions. Not well defined, unfortunately. What about providers? We are the third essentially group of people who were studied in these. Real mixed bag here. Some positive experiences, generally speaking, more negative experiences, but rates were on the low to moderate side. One study found much higher anxiety from going from fairly low to quite high. There do seem to be some impacts based on who you are interviewing and what their role is. So having family members at the bedside, there was one study, nurses were almost always totally fine with it, comfortable having them there. Attending physicians usually comfortable as well. Resident physicians deeply uncomfortable. I think this speaks to experience and comfort level, and resident physicians likely already feeling uncomfortable managing a cardiac arrest, and then adding in the stress of having that person's family member in the room watching you asking questions. That I can understand why that number would drop quite a bit. Another study gathered information on whether family members were in the eyes of the healthcare team helpful or interfering. They did see some like 12% rate of interference from the family, but they also saw more than half the time that there was a benefit to having the patient's family in the room. Those benefits usually meant that the healthcare team felt that the family members benefited from it, and it gave them more of a sense of peace and understanding, as opposed to benefit to healthcare providers or any benefit in hard patient outcomes. Benefit in terms of what the patient was able to appreciate, hard to know. They also gathered information on the hospital environment. They found that there were very low rates of unit policies on whether families can come into the room. This seems to be based on asking healthcare providers. So the actual rate might be substantially higher, and just no one knows what the policy is. I certainly don't know if there are unit policies on this issue in the hospital. Some things that came out of some of the studies were suggestions from providers. So they suggested that having one person that the family communicates through would be quite helpful. And they also wanted some additional training on how to manage the presence of the family. There was one study where they had really impressive rates of having a family liaison. It was generally a nurse who was designated to gather information and questions from the family and relay it back and forth at appropriate times. I think that typically makes sense in a lot of settings in the hospital, at least. You will often find more nurses available than physicians or other people who can really comment on what's happening medically. So this is honestly, it's a bit of a hard study to summarize because there's so much heterogeneity. the results often disagree with each other quite dramatically. And it's hard to pull together a cohesive message. I think we can say that there's certainly no convincing evidence that patients are harmed by having their families in the room. And, impacts on the families themselves can be positive, they can be negative, but I don't think we as healthcare providers are the right people to predict what those impacts are going to be. I think families know their own history, their own psychology, their strengths, their vulnerabilities, and I think they're the people who are best equipped to make a decision about whether they should be in the room. In the next section, we'll talk a bit about some strategies that may make it easier and less traumatic for family members who are coming into the room. But I think overall, the choice should generally be theirs. So that's part one. The next part is talking about the effects that a cardiac arrest has on families and how we can best look after family members after an event like this where one of their loved ones has suddenly died. Again, I was very lucky. There was a systematic review in Metasynthesis published about 6 months ago on this exact question. So this is a review of qualitative studies, and it references multiple times that the authorship includes survivors and family members of patients who have had cardiac arrest. From what I could tell, the author list generally has academic affiliation, so it's not clear to me who they were, but there was input into this paper from people who have actually been on the other side. So this was looking at family members of patients who had cardiac arrest in hospital and out of hospital, only looking at qualitative studies. They took a very broad definition of family members. So this includes children, parents, spouses, long-term partners, close friends, siblings, really anyone who would be first or second call after an emergency. They focused on short-term impacts, but some of the studies that they pulled in included interviews that were conducted farther out. So there is a little bit of a mixture in terms of timelines here. And what they did was they gathered the relevant studies, and then they used a thematic framework to try and extract consistent themes and break it down into a way that would help people who haven't been through this start to understand. So they had a total of 39 studies. Most run out of hospital cardiac arrest or did not specify. They had over 400 family member participants. This included family members whose loved one had passed away or who had survived. And there is a bit of a regional influence here. So this is mostly done in North America and Western Europe, which will have cultural impacts depending on location of practice. So they extracted some themes from the various qualitative studies. And in a lot of places throughout this section, I've included direct quotes from the paper or from patients as appropriate. I didn't, we're trying to understand the care needs of the families, and I think getting it in their words wherever possible is a good idea. I have done a little bit of explanatory work, but wherever possible, these are direct quotes. So these are the 5 biggest themes that they extracted from these interviews and surveys. I'll work through each one in detail, but they sort of follow a chronology through cardiac arrest, starting from the event itself, followed by the actual resuscitation, the crisis around the outcome, whether it's successful or unsuccessful resuscitation, and then after that, once the dust has settled, what now? What care needs exist beyond the first hour of this crisis? So this first theme, when the crisis begins, we must respond, um, generally more applicable in the out-of-hospital cardiac arrest. But this refers to family members seeing the event, recognizing symptoms or disastrous event, and calling for help. It also includes the time where they're anxiously waiting for help to arrive and sometimes starting resuscitation. Uh, Often in hospital, this, if it even does happen, would be very short because help should be immediately at hand. It also may not happen at all if the cardiac arrest is unwitnessed or if it's witnessed by a healthcare provider. But an example of a theme that they extracted is here. You can see that this patient's spouse immediately thought he has died, which is pretty stark. Trying to react to that and move forward and call for help and take any action would be really challenging given the immediate recognition of what's happened. This piece may actually be more relevant in the in-hospital cardiac arrest setting for healthcare providers. So this is something that may happen if a bedside nurse witnesses a cardiac arrest. We may need to think about this type of thought process and the emotions involved for that healthcare provider, because that can be traumatic even when you're not the direct family member. The second theme that was extracted was anguish from uncertainty. We need to understand. So many of us have experience, participating in running cardiac arrests, and even with all the knowledge that we can bring to bear, it's still chaotic. Trying to understand the current state and what's happening next is difficult for those of us with, years and years and years of training and experience. So it's especially challenging for family members. They took some samples of questions that people had when they're trying to understand what's happening. Some are very, very practical. So their loved one is being loaded in an ambulance. Am I getting in the ambulance? Do I need to drive? Should I call someone to drive for me? What hospital are we going to? Where do I park? How do I find them? Do I just go to the ER? Or if it happened in a hospital, is there somewhere I can sit? Is there someone I can talk to? What do I do now? Who do I call first? Just very concrete things about what are my next steps as a family member. There's also explanatory questions where you're trying to understand what's going on, trying to find out from healthcare teams what diagnosis led to this, what is being done to resuscitate them, what is likely to happen next, what are the options, what decisions do I need to make? Finally, there's existential questions. How could this happen? Why is this happening now? How am I going to tell the rest of the family? What is my life going to be like? These sorts of things. As you can see, as healthcare providers, we can often answer the first two types of questions. Existential questions, I don't think it's really our place. We can't really tell people what their life's going to be like going forward. And I don't think it's really the place for it in the middle of a cardiac arrest, but acknowledging that uncertainty can be helpful. And, trying to provide concrete, simple answers to the first two types of questions is important. Patients did say that having some sort of narrative can help, especially if they didn't witness the actual event. It can be simpler for out-of-hospital cardiac arrest because they will often have seen what happened, seen help arrive, seen EMS initiate resuscitation, and then arrive to the ER and everything is still happening. So they will still have questions, but if they arrive and we've been doing resuscitation for 15 minutes, they need to be brought up to speed with some sort of narrative. Emphasis was on plain language and not laying out hope where there shouldn't be, being realistic about what people are facing. And here's an example. So you can see here that this family member really appreciated the honesty, that this was a dire situation, may not be able to recover the patient. And you can also see there's there's some information in there that the patient can hold on to, some if-then statements. If he starts to bleed, there is nothing more we can do for him. That provides something concrete. It provides something that they can anchor on a little bit. And then if there is bleeding, they're prepared for what that means. So this is the type of communication that patients found to be helpful. Next is that patients have family members who know them intimately, and this was the next theme. Partnering in care, we have much to offer. So family members want to be helpful. They want to do something for the patient. They want to help the healthcare team with their task. Generally speaking, family members also found that having a designated spokesperson within the team was helpful. I find this very interesting because that's the exact thing that healthcare teams reported in the prior section. So having one person who they can find and talk to and relay information to and get information to, very helpful. They may want to talk to the patient. They may want to say goodbye. They may have religious rites that they may want to provide for the patient. And this is also an opportunity to incorporate shared decision-making. If they're outside the room and trying to relay information through different people who keep coming out, it can be hard to bring the patient's values to what's happening. Whereas if they're in the room, it may be a little bit easier. So here's some examples. So even if it's bad news, this family member found that that was better than waiting down the hall, not knowing anything. The fourth theme was the crisis surrounding the patient. Ignore us, the family, no longer. So this is about the emotional needs, physical needs, existential needs of the family. These are things where we can hopefully provide some small comfort. Even if it's an example, this was an example given from one of the papers, just the fact that they were told that their loved one didn't suffer, even that was a small kindness that they could take away from it. They didn't want unrealistic hope. They didn't want to be given misinformation, but trying to find something that they could hang on to as a small silver lining was useful. They did want to have an advance warning before seeing anything traumatic. So before going in to see a cardiac arrest, a brief description of what's going on and what they may see would be important. And there's also discussion about physical needs, particularly for loved ones of survivors. This came up more frequently where they don't want to leave the bedside, but there's really nowhere to sleep except a chair, which doesn't always recline. They didn't know how to get blankets. They needed to charge their phone. They don't know where to get food. They don't know where to get water. They have all these needs. They're trying to be there for their loved one. They're trying to, manage their own emotional state so that they can be helpful to the healthcare team. And if they're hungry, thirsty, and sleep deprived, it's more challenging to do all of those things. So this is really speaking to the physical aspect where sure, they were offered to stay as long as they want, but what if they need something? What if they need a phone? What if they need to go move their car or it's going to get towed? They have they have things on their mind that will distract them if we don't ask and try to address those things. The last phase is, reflecting probably something that I at least have been involved with the least or negligent the most. And it's about how the emergency goes on for the family. So our family's emergency is not over. Now is when we need help the most. So after the arrest, whether the patient survived or not, the family has needs. A lot of articles suggested an early emotional debriefing for family members to try and help them understand what happened, start to process emotions, and start to identify what their needs are. For patients who survive cardiac arrest, a lot of their family members found that discharge from hospital led to a dramatic change. So all of a sudden, their supports dropped away. They couldn't ask questions as readily. Their information, it wasn't cut off on purpose or anything, but we discharge people to the community and their follow-up is in a month. Well, what if they have questions in a week? They found that this was a big area that caused them a lot of stress. And finally, follow-up for survivors of arrest can be complex. It can be hard to navigate, involve multiple specialists, and you often have a family member who has transitioned into a caregiver role, who is trying to navigate all this while dealing with their own, trauma, their own difficulty sleeping. They may be developing symptoms of PTSD, and they're trying to manage all of that for themselves while also managing all of the follow-up care for survivors. So this is an example of the abrupt cutoff after discharge, where this family member feels like, they're discharged and they're alone. Good luck. See your specialist whenever they book for you. Just a feeling that they've lost a lot of the support that they had before. I just wanted to put this back as a quick little summary of the themes that they extracted. There wasn't a specific conclusion or, this wasn't a meta-analysis in the quantitative sense where they could say this medication is better than this medication, but these were their results. These are the themes that came out, and you can see how they would arise as patients progress from initial onset of cardiac arrest through to either their passing away or surviving and moving into recovery. So I had some final thoughts, and doing this reading gave me some things that I want to carry forward in my practice. So it helped solidify that offering families the opportunity to come into the room is unlikely to be harmful. And if the family thinks it will help them, we should certainly offer that, is my takeaway. And I hope we've already been doing this, acknowledging the first couple of themes where there's pain, there's uncertainty. In some cases, there's guilt for not doing something sooner or not knowing CPR, and being able to talk to people and help them work through that and acknowledge what they're going through is important. And this reinforced that for me. A couple of takeaways. I think I have not traditionally included a designated person to talk with family members in my teaching room of practice around cardiac arrests, and I think that is of value. The MRP service, if it's not the same as the person writing the code, I found that the MRP service often takes on that responsibility. But having someone given that responsibility, and that is their only responsibility, I think is important when you have lots of people available. And then I think the biggest lesson for me is that after resuscitation, follow-up down the road can be a real challenge. if someone survives a cardiac arrest, they're usually not coming to my care immediately. They're usually going to the ICU, but they may come out to internal medicine afterwards and be discharged from our service and then feel like all of a sudden they're cast about on the seas and they don't know where to go next. So that's something that I took away as something that I want to change in my practice. And now I'd like to open it up for questions, commentary.
Thank you so much, Hugh, for this in-depth analysis and evaluation of the literature and in a topic that's doesn't have much randomized controlled trial, right? So thank you very much looking at the available evidence and coming up with a synthesis of what's going to change in your practice. If you have a question, please put it in the Q&A or raise your hand. So I will bring you into talk. And I see Dr. Levine would like to ask a question or comment. Mitch, please go ahead.
Yeah, I think one of the other conclusions that I drew from your talk, which was really, really very good, trying to summarize this, is that the reality is in this area, there is no one right answer for all circumstances. And I know you're trying to kind of come up with some general principles, but, I think it also depends, if it's a son or daughter and the parent has the arrest is different than if it's a parent and the son and daughter has the arrest, or if it's a spouse to spouse kind of. And ethnic diversity would also need to play a role. So how we respond really needs a lot of flexibility to the individuals who have different needs as well. So there's not one kind of answer to all of this. So I thought that would be like one other conclusion you would come to from your review as I kind of listened to you.
Yeah, absolutely. There's certainly no algorithm to follow. And oftentimes trying to get these cues from the patients about what their needs are, I think that's probably one of the best ways we can figure it out, because I totally agree. There's no one right answer for this.
Thanks.
Yeah, I mean, in following up to Mitch's comment, it sounds like, there have to be sort of a process of counseling to the family, whether they want to be in or not, at the time that the focus is basically restating the patient, which you've touched on, you in your conversation. So my question is, are we beyond the medical team that's running the Code Blue, or with the Code Blue team, are we equipped as a healthcare system in hospitals to have people allocated, to have that conversation with the family and support that family, not only before, but during and after, as you pointed out, arrestation, right? So.
Yeah, that's a really good question, and something that I was wondering as I worked my way through these papers is whether the hospital has a designated role for this, because I think when you're at the code, I think it would be challenging to have somebody pre-designated to be a liaison at every Code Blue. But I think identifying, a ward nurse or a charge nurse or someone who knows some of the medical situation can be calm and be a good liaison for the family in the moment. I think that is a role you can come up with at the time, but I don't know of any, broader hospital-based role for that, for checking in with families thereafter. I know I haven't been doing it as an MRP, and I haven't come across any evidence that that's happening. It'd be a bit of a challenge to designate, I think.
Yeah, I think as you've pointed out, there is also like the difference is going to happen significantly about what time of the day this happens. So if this happens during the day when the team is around and knows the family and there's this support and connection between the family and the team is one thing, compared to this is a midnight event that literally no one on the Code Blue response team is aware of who the patient or who the family is, and that relationship does not exist at all, right? I wonder if there's actually a role for the hospital, understanding that the code blue teams, although in the Department of Medicine, they're run by our either SMRs during the night or during the day, and the presence of the faculty at times depends on the site. But it is responsibility of the hospital. So wondering you if you have been in touch at all with the code blue committees that actually put together who is the team that should respond, and whether be part of that, but part of that group, someone is designated to take on charge of talking to the family and supporting the family.
That's a good idea. Maybe I'll reach out.
Yeah, I find this is going to be the last thing a code blue captain or a team leader, would think about, when the patient does not have pulse, right? So,
yeah, I've often found if someone gets designated, it's usually, a senior person, either an experienced resident or fellow, or a staff has shown up after and is doing crowd control and trying to designate people to do roles, and they will often take on that role of either facilitating, or they'll assign somebody to talk to the family members as opposed to the primary code leader doing it. But then it's still ad hoc and you don't have someone designated.
Yeah, so I think it'd be really nice to bring this evidence that you've done amazing job in distilling for us, to the code blue committees. And actually, I think at least in one of our institution, one of our internists is a co-chair, if not a chair, for one of the code blue committees. So we should be able to have an influence there. You started your conversation saying, you and I, and later on in your presentation, it's in your role as the educational lead, simulation educational lead for the residency program. So how are you going to take this knowledge and educate? I find it's not going to be an easy, piece of work.
No, I agree. I'm going to incorporate some pieces of it into the training for first-year residents, just the very basics about, it's okay to offer to have the family come into the room. And, if you are 15 minutes into code and things have quieted down and you have some spare people, maybe see if someone can act as a liaison to the family. I think a lot of this, I worry about including it too early in the curriculum. So maybe something later on as a refinement in running cardiac arrests rather than an initial teaching. I could include it in some of our refreshers later on in training.
Very good. It comes to mind. I started by commenting, saying like I was trained in an era where we used to literally kick the family out of the room. Are you aware of this ever still happening, especially if a family did demand being there or ask being there? Do we know if people are still telling families to leave the code blue scene because we don't know how to handle it?
That's not something I came across in my reading. Most of the studies, they would either say they included family presence or families were not present. Like there was no randomization or assigning to groups. So I took that to be as a more natural phenomenon. I think there may still be that happening at the outset, like in some of the really small rooms, or if an arrest doesn't happen in a room, but it's a small place, you may literally just need them to leave in order to facilitate moving the patient to a bed or to a place where you can provide care. But I have not seen that happen in my practice. I haven't also seen anyone being so disruptive it would be considered for that reason. I didn't come across it in the literature. So from what I can tell, in North America, in Western Europe, at least, I would say probably not.
That's good. That's good to hear. There's a comment from Dr. Martin. Thank you for an excellent summary of a really important topic and for your commitment to educating our trainees through SIM. So we echo the comments. I don't see any other questions or comments, Hugh, and I don't have any more to probe. So I think it's been, as I expected, a fantastic talk, actually way more than I expected in the literature review piece, which is great. And thank you very much. It's a difficult one. and you've done a fantastic job. So I really appreciate the time you've put into this, and I enjoyed your talk, and I'm sure everyone else did. So thank you very much, and have a good rest of your day, everyone.
My pleasure. Thank you.
Bye. Take care.